All righty. Welcome to the New Mexico Family Advocacy Program 58th ECHO session. The NMFAP is a model of respondent parent representation being implemented in the 2nd, 13th, and 11th judicial districts. The program utilizes interdisciplinary teams of lawyers, social workers, and parent mentors that provide high-quality representation and the advocacy and support families in the child welfare system need for reunification or other preferred outcomes. I am Quiva Hubbard. Hello, everyone. And we have Jen Vieira on IT support. And today's topic is evidence-based practice, why and how to advocate. One second, let me move my thing up. Reminders. So that we know who is with us today, please enter your name and email address in the chat. Please fill out the post-session survey, which is an integral part of our program's data collection efforts under the federal grant. The survey will take only a few minutes of your time. Corey will post a link in the survey in the chat. Thank you in advance for your feedback. And Corey has already posted that link in the chat. And 1.2 general continuing education, legal education credits will be offered to participating attorneys by our sponsor, the Korean Wolf Center for Child and Family Justice. The form is located on the program's website, resource library, and will be added to the chat. 1.25 continuing education units will be offered to participating social workers. To receive, you must email echonmfap@gmail.com by the end of the day on Friday, February 17th, indicating that you intend to receive the CEUs. The email address will also be added to the chat. All righty, so an introduction of our presenter today. We have Bryce Pittenger. Did I say that correct?
Yes, ma'am.
Who is a licensed professional clinical counselor and the CEO of the Behavioral Health Collaborative for the state of New Mexico. Ms. Pittenger began her career in mental health in 1997 after graduating with a master's in counseling from Southern Western College in Santa Fe, New Mexico. She worked in private practice and community mental health in a variety of settings with people experiencing mental health illness, specializing in children and youth with trauma and problem sexual behaviors. In 2014, she began working for the state and became clinical supervisor of juvenile justice services. In 2015, she became deputy director of behavioral for juvenile justice services. And in 2016, she became director of behavioral health for children and families, overseeing programs, grants, services, and finances. In October of 2020, she became full-time CEO of the Behavioral Health Collaborative with HSD, serving all of New Mexico's populations and communities. Woo! Wow, that's amazing. It's impressive.
Sounds exhausting.
As CEO, she creates a statewide strategic plan and combined budget for the implementation of behavioral health initiatives across 17 voting state agencies and New Mexico communities. Ms. Pittenger believes in the power of collaboration to create a trauma-responsive system of care for all who need mental health supports or services. All righty. And some of our learning objectives today, by the end of the session, participants should be able to better understand the Kevin S. Settlement Agreement and its importance, know why we need evidence-based practices, and name one evidence-based practice that will roll out in New Mexico. All right, and just as a reminder, the session ends at 12:55.
Perfect. Thank you so much, Quiva.
You're so welcome.
So my name is Bryce, as Quiva said. I'm the CEO of the Behavioral Health Collaborative, and I'm really happy to be having this opportunity to tell you a little bit about what we're doing at CYFD AD. But before I begin, on behalf of our colleagues at Human Services and the collaborative statewide, we humbly acknowledge that we live, work, and play on the unceded ancestral lands of the first peoples of New Mexico. And with gratitude, we pay our respects to the land and the people and the communities that is now known as New Mexico. So system change, it's a big topic. Where do we start? on the right-hand side of the screen, you can kind of see what is now evolving as the pair of ACEs, which is adverse childhood experiences, which you all are familiar with, abuse, neglect, witness to domestic violence, incarcerated parents, parents with mental illness or substance use. But there's also adverse community environments, poverty, discrimination, community disruption, lack of opportunity, poor housing, quality, and affordable care. And I will give you one short example, which is 2 years ago, I moved to a neighborhood with parks and trees, and the quality of my life has gone way up. I would say that in the summertime, my neighborhood is about 10 degrees cooler than the neighborhood I used to live in, encouraging me to get out, encouraging me to be part of my community. So when we talk about system change in New Mexico, we can't talk about it without stating, what we all know, which is that we are at the bottom of the list in child well-being. Our 500,000 children here in the state of New Mexico, 2.1 million folks, are struggling with colonialization, intergenerational poverty, historical trauma, lack of opportunity in some of their environments. And so as we talk about the children in state custody and the part of the reform that we're doing both for adults, children, and specifically children in state custody, just bear in mind the impact of that trauma and the impact of those social determinants of health and the impact of stigma. And we're talking now a little bit more about structural determinants of health. This conversation is leaking into our circles, and I think it's a really important thing to be aware of and to further the conversation, which is the water we swim in. It's the racism, it's the sexism, it's the colonialization of our systems that our systems are built on. So as we aim to change certain aspects of the system, we have to look at those underpinnings to really find where some of our children need to be lifted up. So just a really brief overview. What is the Kevin S. Settlement Agreement? And this is really the only slide where I'm going to talk about all of the appendices briefly. And I certainly would come back or get you somebody else to more information if you are interested. But basically, CYFD and HSD were sued on behalf of 13 children that were in foster care by the Native American Disability Center, Disability Rights New Mexico, and others. We entered into negotiations and we ended up with a settlement agreement, not a consent decree. So we are in a good faith agreement that we will hit our targets of system reform. And those targets include a trauma responsive system of care. And I'll talk a little bit more about that in a minute. Least restrictive and appropriate placements. We've made some great strides in this with regards to our children being placed first with relatives, second with fictive kin. And so we've had a large increase of children placed with kin, and we've had a large decrease of children in congregate care settings, especially in out-of-state settings. So this part of the settlement agreement really aims to have a resource family or foster family network that reflects the diversity of our children. So they will feel as safe and normal as humanly possible as they go through this incredible ordeal of being taken into custody. So the third one, is the Indian Child Welfare Act. And this is really about just cultural considerations. As you know, last legislative session, we passed a state ICWA. As ICWA, the Indian Child Welfare Act, has some challenges by folks nationally. We believe that our state ICWA plan that was adopted into statute last legislative session was created with and for the tribes and nations, and really had at the center, the forefront, their sovereignty, their respect for their cultural traditions, and to bring forward those pieces as they enter into any kinds of conversations or with us around their children. And the fourth one is the behavioral health services. So it's really about increasing behavioral health services. And I talk mostly about that today. Basically, how this is set up is that we had 3 co-neutrals. I put Pam Hyde in red. I care about her. She's an amazing person. She was the HSD secretary under the Richardson administration and really started the Behavioral Health Collaborative. She is no longer with us. She has retired. So right now it's Judith Meltzner, who's a national expert in the Center for Study of Social Policy, and Kevin Ryan, who actually reformed New Jersey when they were sued and really did some wonderful things with that. So what is a trauma response approach? Why do we care about it? So basically, as we were going through these negotiations, some of us sort of brought up that trauma-informed is one and done at this point. If you haven't heard of trauma-informed in your world, I would be really surprised. But trauma-informed basically is that we understand that the people we serve experience trauma, that we try to prevent re-traumatization as they touch our systems, and that we understand that working with traumatized folks can create vicarious trauma or stress in us as individuals. So we take care of ourselves and the people that work for the children and families. So what does it mean to be trauma responsive? It takes it up a notch. It means to act with the appropriate sense of urgency. All of this, understand that the children we serve and the families that they come from have experienced trauma. Maybe the pair of ACEs, maybe it's generational. And so to respect that and to act with the appropriate sense of urgency, using the children and family that we serve as the guide. So I'm going to start really quick, just giving you a brief overview about the CAT and the CANS. The CANS is the Child and Adolescent Needs and Strengths. There are over 35 states in our nation that utilize the CANS. It's developed by Dr. John Lyons and the Prayed Institute. And we worked with Dr. Lyons and Dr. April Fernando for quite a while to redevelop our CANS. We already had deployed a comprehensive trauma-informed CANS prior to the settlement agreement, but part of the settlement agreement was an approval of that comprehensive CANS. So we loaded it. We loaded it with early childhood modules. We loaded it with caregiver strengths and needs, so we can rate the actual family or the resource or foster family and really understand what their needs are for supervising that child, for caring that child, for supporting that child culturally, for meeting them where they are. And so the CANS is a community metric validated tool. All that means is that it's about system change. Community metric means that each and every metric is validated in and of itself. And that's why states can really build what they need, like our transition age youth module, our sexual harm module that we built within the CANS. And so the idea there is that we create a common language to talk about children and caregivers' strengths and needs. Why is this important? Because you've been in circles where people have brought stigma to the table, and you've been in circles where people have talked about children and their families in a way that is not trauma-informed or trauma-responsive. The CANS gives us a community of language to talk about our children's strengths and needs and their caregivers' strengths and needs. It's loaded with traumatic symptoms, so we can look at running a course of treatment and then redoing the CANS and seeing if some of that symptomology came down. And right now, the CANS is done it's done within the first 45 days of that child being in custody. The CAT is a short version of the CANS. It's done between the 48-hour hold and the 10-day hearing. And the reason for that is the CAT it just pulls out some of those emergent needs: suicidality, homicidality, self-harm, sort of major depression, substance use. So the CAT is done as we are learning and entering into conversations with that child and their extended team. And so we're able to identify early on what those emergent needs are. So you can see right here on the right-hand side of the slide, this is our rating scale for needs, 0, no evidence, all the way up to 3. When this is done by our investigators, the CAT is done by investigators at CYFD, the CANS is done by PPWs, by permanency planning workers. And our CBHCs, if you're familiar with the juvenile justice and crossover youth, our clinicians, our community behavioral health clinicians, do the CANs on crossover youth. And although it's not part of the settlement agreement, I think it's important to know the CANs is used broadly in juvenile justice to understand what the needs and strengths of those children are. And it sounds a little amorphous as I speak about it, but if you really dig into the details, and I'd be happy to share that link, the CANS rating sheet and manual is available on the cyfd.org website. As once things are approved, we publish them. And so I'd be happy later on to share that link. So, oh gosh, sorry about that. So the tribal sovereignty and cultural connections and cultural humility, there's a lot that goes into this when we're looking at reforming for a subgroup of people. If you look at CDC's population health strategy for behavioral health, equity is a big one, and so is transcultural as well as cultural. And what that means is that there are certain things that are transcultural: depression, domestic violence, alcoholism, anxiety. These things are across cultures, but how they land in specific cultures is really important to understand, and leveraging the community wisdom of those cultures to be able to identify what their needs are and where they want our help is absolutely key. So the humility is really important. These tribes are sovereign. It's not for us to determine what traditional practices are. It's for them to tell us and maybe share not all of it, but what they want to share with us in order to meet the needs of the child. But the idea there is really being able to lift up our relationship with our tribes and nations on behalf of the children and to pay special attention to their cultural needs and traditional practices. So just really briefly, our Medicaid 11 waiver, MCO procurement, this has been stalled out briefly, but the waiver renewal includes an MCO managed care organization that's specific to children in state custody. We call it an acronym because people love an acronym, CISC, Children in State Custody. So you may see that in quite a few places. So some of the features of that: high fidelity wraparounds, which I'll talk about later, actually my favorite service that we offer, a closed loop referral system, so we understand what the needs are of our communities and can meet them, continuous eligibility for children up to age 6. We also extended Medicaid coverage for postpartum women. It used to be, I think, 3 months when I was having my babies. Now it's a full year. And so I think that Director Nicole Camo, who's no longer with the state, really thought outside the box and leveraged everything she could for children and families in New Mexico. A couple of home visiting programs, new evidence-based models that will go live in this waiver, and you can see them there. Native American member-directed reimbursement for tribal healing. This already exists as a value-added service in our managed care organizations with a cap. We also have a pot of money at HSD and a pot of money at CYFD, where we can pay for traditional and tribal healing services for children in state custody. So one of the MCOs selected in this procurement process, they all had to apply to be the CISC MCO, one will be selected. So the behavioral health provider network, what have we done? Well, I'm just going to stick to our system reform related to the Kevin S. settlement agreement, because otherwise I'd be talking to you for the next 2 hours. So we contracted with Myers and Stoffer, and we had the universe of children, our providers who serve children in state custody because of our claim status. So what we did was a deep dive into understanding what all those services were, all those providers, whether they received Medicaid or not, whether they were in a primary care or a hospital setting or not, all of the universe of claims and providers for the CISC population. And so what we did was we surveyed them and we did some focus groups with them. And we started to understand what the barriers were for evidence-based practices for our provider network. And they said to us very clearly, yes, it's great you'll pay for the training, but it's the rate reimbursement for Fidelity that we can't do it without it. And so we heard loud and clear, and we entered into rate development for these six evidence-based practices with another actuarial firm that Medicaid contracts with called Mercer. It took us about, I would say about 8 months for the high fidelity wraparound alone. We submitted that to CMS for approval, which is still pending. And these MST, FFT, DBT, EMDR, and TFCBT, we've built a Cadillac, and we looked at providers in rural and frontier areas HRSA designations, meaning that it takes 45 minutes or over an hour to get to a provider. How do we look at those networks across the state and build capacity by, sort of a pay differential, recruitment and retention differential based on where you are and who you are. So what we've done is built some Cadillac rates. We're hoping that these will be approved by CMS and go live July 1. So July 1, these will be available for fee schedule. We've developed a really great practice process with NMSU Center of Innovation, which I helped create when I was the Director of Behavioral Health under CYFD. And the reason we created it was because we had lived through administrative changes where everything came crashing down that we did. And so one of the things that we learned from our partners in other states was that folks created Center of Excellence or Center of Innovations and partnering with the local university in order to champion those evidence-based practices regardless of what happens in the political landscape. So let me just go back really, really quick here and just tell you, when you get this, all of these are hyperlinks to the websites of the evidence-based practice holders that we're utilizing. And then this is a cheat sheet for you. I have over here the names of these evidence-based practices, sort of who they're for, their age, their caseload size, and their average episode of care. And I told you about contracting with NMSU for provider rollout. We're ready to go with that. So as soon as we get approval from CMS for this new 11/15, July 1, we'll go live. So let me talk a little bit about the specific individual evidence-based practices. So trauma-focused CBT. Trauma-focused CBT, there's a couple of these that we're bringing up, not just for children in state custody, but for adults as well, and all children, okay? So this is for adults as well. So this will be flooding, hopefully saturating our behavioral health provider network with an understanding of a short-term treatment model that deals directly with traumatic related behaviors and symptomology in sort of shorter sessions, 8 to 25. A caregiver participation is key in this, not as key as when we get to MST and some of those others where the caregiver participates weekly, but this you need to know. They need a viable caregiver to be able to support them. One of the things that you should understand about the child welfare world and trauma, Bessel van der Kolk wrote a book called The Body Keeps the Score, best book on trauma I've ever read in my entire life, if you want to take a stab at it. And he boils it down to some beautiful, sort of poetic understanding pieces. And one of them is that trauma interferes with the sense of safety with self and with others. So if we're to boil the impact of trauma down for a child in state custody, their sense of safety in their own bodies has been compromised. Their sense of safety in their relationships with adults or other children has been compromised. So safety, both internal and interrelational, becomes the primary target. Evidence-based practices are just fancy ways that are proved of data, collect, intervene at certain, intervene at sort of different spots on the map and allow for that safety to emerge. But an evidence-based practice for children that doesn't take on safety, physical, emotional, psychological, and relational safety, I would question it. So this is about a PTSD diagnosis. So when you're looking at referring for children, once we have TFCBT up and running statewide, you don't have to have a diagnosis. You can have trauma symptomology. So it's a lower threshold and effectively addresses impacts. And let me just talk a little bit about that. That's a hyperlink to the child welfare sheet there. So TFCBT utilizes components of cognitive therapy, which is about, the way we think and what our core beliefs are and what we tell ourselves impact how we feel and how we behave. Behavioral therapy, which focuses on modifying habitual responses. And so this can be, if you think of trauma, you think of PTSD, think of hypervigilance, right? And that may be one of the pieces that would be addressed in that way behaviorally. Family therapy, because the child needs that interrelational safety and support. Attachment, which is really about, let me boil this down for you and just take this with you, please, for you, for your children, for the people that you serve. That attachment's about us having our own mask on first as the airlines give us that great advice, regulating our own selves emotionally so we can help a child regulate. If you've ever tried to pick up a crying baby when you're really anxious, you understand what I'm talking about. It just creates more anxiety dynamic with that baby. And so being able to put your own mask on first and emotionally regulate yourself before you come in contact with the child that could be dysregulated, or a child that has trauma, whether you're seeing them in your office or a courtroom, that's one of the most important things that you can do for that child, is for you to be regulated and so they can tune into that. Developmental neurobiology, again, if we had a lot of time, I would tell you about that, but basically how the brain develops. It's use dependent, develops from the back, meaning the impulse and protection pieces first to the front, the frontal lobe being the last part of the brain to develop. So all of that awesome stuff that we pride ourselves on, adults being able to think about things down the road, being able to think about consequences, being able to have empathy, doesn't really happen until 23 to 26 in children. So here's the practice model. So utilizes some of the psychoeducation, relaxation techniques, effective expression and regulation, coping, trauma narration and processing, in vivo exposure if appropriate, and then joint family sessions. Not quite like our infant mental health program with the child parent psychotherapy, where the dyadic relationship between the child and the parent is the focus of the treatment. Not quite like that. So just a little bit of a difference. And then enhancing personal safety and future growth. So I want to talk about dialectical behavior therapy. So this is the second evidence-based practice. This is a bundled rate. So this will be, I am a DBT therapist. I used to be a team lead when I was at Hogatis, was the organization in Albuquerque, Torrance, Grand Sandoval, Valencia. And we had a DBT team for adolescents. So who is DBT for? DBT is for people that have over, and this is adults and children, so we're bringing this up broadly, not just for children in state custody, but for adults and children broadly. People that have overwhelming emotions, children that have impulsive behavior, self-injury, suicidal thoughts, substance use, eating disorders, trauma, challenging relationships that are filled with conflict or arguments. So if some of you are hip to our DSM-5, you're starting to notice a trend, which is that DBT was built by Marsha Linehan, who struggled with borderline personality disorder herself, and based on a skill deficit model. So there are 4 real components of DBT, and there is DBT currently. I know that even UNM, not even, but UNM has DBT in their outpatient, but there are several in New Mexico, in the Albuquerque and Santa Fe area, but that's about it, that do it with fidelity. 4 modes of standard operation for DBT: individual and family psychotherapy, right? So that's one. DBT skills training. And this is that thing that we base the borderline personality, sort of traits on a skill deficit model. So we need distress tolerance, we need interpersonal effectiveness, we need emotion regulation, we need mindfulness. So these are the skills that we train. In the way that I did it, it took us about a year to take an adolescent and their family through the skills group training, because sometimes they needed to do a module 1 or more times, and they needed to do it with different caregivers. So 6 months to a year is about the range for that. And then in the moment phone coaching. This is when the adolescents call us from the bathroom after they've cut themselves, and I'm not kidding. And so this is where DBT is a 24/7 service. So if I'm a DBT therapist, I am on call 24/7. And that can change because you're part of a team, so you can, get your nights off or whatever, but it doesn't stop when the office is closed. Some of the most important work happens with the coaching. The diary card is a part of that, which is basically a mood tracker. So we track certain things. It's like homework for the children and their families. And then the DBT consultation team. The consultation team just really acknowledges that this work is very challenging and very difficult. It's really hard to attend the bedside of a child that attempted suicide and sit with them as a therapist and welcome them back into this modality. So what we do in the consultation team is support the therapist. We do our own mindfulness. We do our own clinical supervision. We do our own training, and we unpack. And we don't have large caseload sizes in DBT because of the nature. So if you look at this, and just this is the DSM criteria. Is my little thing in the way? Sorry if it is. Move it. This is the DSM criteria for bipolar personality disorder. And this is the curriculum for the skills group. So mindfulness. Every session we start with mindfulness. I don't care if it's individual, group, or family. Emotion regulation. Let me give you an example of emotion regulation. It's to cope ahead. So today I knew I was speaking to you all. I also knew that my office was closed and I had a day off. I had coffee. I played computer solitaire. I took a bath and I got ready to meet with you. I coped ahead. Distress tolerance. This can be as easy as temperature change and putting some ice on the back of your neck to cool the ventral vagal nerve that creates a lot of anxiety. And this can be as simple as distracting yourself from your pain. Interpersonal effectiveness really has to do with, communicating more effectively to the people that you care about to build more long-lasting and reciprocal relationships. And then the behavior chain analysis, I just stuck that in there because I think it's important for you to know when an event does happen, like the child tried to cut herself in the bathroom. That was a real live example that I had. Called me, she was bleeding. We handled it. We handled it in a couple of different ways in terms of getting mom on the phone. Mom was able to get in the bathroom. We were able to get her to the hospital, not by ambulance. She did not get admitted to the hospital, but treated for her injury. And what did we do the very next session? This is what I did. I did the behavior chain analysis. What were her vulnerabilities moving forward? Was she hungry? Was she tired? Was she angry? What prompted that event? What do we know about her and her family? What were the links in the chain that led to the problem behavior? And what were the consequences of that behavior? I'm going to pivot and watch my time and talk about functional family therapy. This is another evidence-based practice selected by the plaintiffs and agreed to in the settlement agreement. Functional family therapy, this is also an evidence-based practice that we call a bundle. So that the practice includes individual sessions and family sessions. This is generally provided in the home, when I was in juvenile justice, my apologies, I did a pilot long before COVID with functional family therapy and children in juvenile justice in rural and frontier areas that had no access. We put a computer in their home and we delivered FFT as usual, except for the telehealth. We evaluated that program. I showed my evaluations at the LFC, and pretty amazing stuff. Not only was it as effective, but folks found it a little bit more doable, because if you think about these evidence-based practice, folks, I want you to understand this is a time commitment. So if I'm grandma and I'm taking care of my little granddaughter because, you know, I'm the relative placement, and I'm looking at one of these and you're telling me you're going to be in my home a couple of times a week, I'm going to need some engagement, motivational interviewing style to really understand what some of these benefits are. Why should I let you in my home? Why would this work for me? Can you tell me about how this works for African-American families? Can you tell me about how this works for Asian families? And they should be able to. So services are short-term and can be conducted in clinic, but the majority is home. Schools are school-based health center, child welfare facilities, and it is fairly flexible, could be absolutely provided, and probation and mental health facilities as well. So FFT integrates several elements. I talked a little bit before about, you know, sort of what went into those evidence-based practice before. So that the model has 5 specific phases: engagement, motivational interviewing, folks. Motivation, do you have the can we link with the motivation to change for that individual and for that family? A relational assessment. What does the relationship look like between the child and family? Behavior change, when we start to see it, we celebrate it, we link to it, and we start to understand what lifts it up and what brings it down. And then we look for that generalization. So not just about the specific problems that child and family come in initially, but it is the impact of this modality generalized sort of across settings. So it's a short term. This is, if you know anything about the Family First Prevention and Services Act, FFT is on the clearinghouse, meaning that it could be utilized in a way for prevention for our Title IV funding. However, this will be Medicaid eligible and will require a diagnosis. Typically, therapists meet with families face-to-face for 60 or 90 minutes and by phone for coaching. So the next one, just staying on track here, is multisystemic therapy. You should be familiar with this as well. This is an evidence-based practice with a high return on investment. This is also available. I mean, this is also, what's it called? Included in the California Clearinghouse for the Family First Prevention and Services Act. This is community-based, family-driven, typically for antisocial delinquent behavior in youth, typically for crossover youth or juvenile justice youth, or youth that are at risk of entering into our juvenile justice system. So you may, you know, at this point, it's about 60 children a year, and that take that with a grain of salt. It's been 2 years since I've been with CYFD, but about 60 children a year that are on formal probation and are in state's custody. But there are lots of children throughout the year that we as juvenile probation handle informally. And so the idea there is, if there is a viable caregiver for this child to participate in this intensive service, that would be a great candidate. Someone who's a child in state custody who's just starting to get into some legal trouble. MST believes in the entire ecology of the youth. So the child's at the center, but is surrounded by family, peers, school, neighborhood, community, culture. So the child's embedded within multiple interconnected systems. And so therefore, you have to intervene in all of these systems in order to create the change. Highly structured clinical supervision and quality assurance process, meaning the fidelity fees are through the roof for this, honestly, and folks meet weekly with national experts to staff cases and to get direction. MST focuses on the family as solution. Families are full collaborators. I'm just going to be straight up with you all. That some folks have, I'm going to own it. Some folks and myself have a caveat with MST, that it really focuses on the family. When I was in juvenile justice, there was quite a few young people that I was working with that said they barely even talk to me. And so it has to be the sort of right modality. If a child's in a family setting, that could be improved by a focus on those parents for setting up structure and for maintaining that structure in a loving way to really corral and hold that child, then that could be really impactful. So the idea here in the theory of change is that MST improves family functioning by directly intervening with peers, school, and community. So the MST is a bundle, but it's an inclusive service. You don't add MST and CCSS, for example. You could add MST and high fidelity wraparound. I'll get to that. But so the idea is that MST does this case management, meets with the schools, works on this with the child and with the family, may even go to events with the child, and also with the community and legal. And so the idea is that reduces antisocial behavior and improves function. So inclusionary criteria. There is a specialized kind of MST. I was trained in this years ago. It's called MST PSV, problem sexual behavior. There are a couple of folks here that do problem sexual behavior MST. I find it to be very effective way of treating problem sexual behavior, but it is a specialized approach. So once MST is broadly available statewide, you're going to have to ask, do you do MST for problem sexual behavior? Exclusionary criteria, youth living independently. They've got to have a non-exploitive adult go through this process with them. Youth with moderate to severe autism or difficulties with social communication and interaction, repetitive behaviors. Therefore, the origin of some of these difficulties might be more organic and not about the peers, community, or family. So this may not be the appropriate treatment. Actively suicidal, homicidal, or psychotic, and youth with psychiatric problems that are primary reason or have chronic or serious psychiatric problems. So this is kind of what it looks like, these 9 principles. This is and I'll give you this PowerPoint if that's okay with Quava and Leslie, guys. So this is the idea, is work's done in the community and removes the barriers to service access. EMDR. So I'm also a trained EMDR therapist, level 2. I got trained about 18 years ago and utilized this in private practice. I find it to be very effective, but I'm going to caveat the heck out of this for our children in state custody as we move forward. So EMDR uses a 3-pronged protocol. Basically, we look at the past events that have traumatized that person, laid the groundwork for the dysfunction. The current circumstances, so how that distress manifests in their life, internal and external triggers, and then imaginal templates of future events. So this is, I call it melting in, melting in the positive future, melting in the safe space. That's the language that works for me, and I primarily have worked with children, and it works for them. So Francine Shapiro was working with vets when she sort of came across this, and recognized that when the visual center crosses the midline of the body, it appeared to be that the adaptive information processing model, some sort of like almost like reset processing mechanism within us that happens during REM sleep, was activated. And so she wanted to know more. So she started a lot of trials, and she started creating just, sort of a more of a framework for her model. And it is one of the most effective modalities for single trauma. Complicated, complex trauma in children is a little bit difficult. You're not going to send a child that has had multiple chronic traumatic events over lifetime by multiple individuals to EMDR and think there's going to be a magic button. But for a single trauma, works really well. And for trauma, when a child has a safe space inside and a safe relationship, can be very helpful. And this is the only picture I could find on the internet, apologize, but basically safe space inside. So doing EMDR and attempting to process traumatic events without first looking at, does that child, is there anywhere safe they can go? So when this ab reaction, when this emotional material comes up, I can stop the session and take them back there to that beach, take them back there to that cactus by their grandmother's house in order to equalize the distress that has flooded the system. So if a child is not safe, and if that EMDR practitioner does not tell you that that child needs to be safe before they do the EMDR, then I wouldn't do it. So again, across the board, this is proven effective with adults as well. We've got over 600 EMDR practitioners. You can go to emdr.org or .com, and you can see there's about 600 here in New Mexico or more. That's just the picture from the internet. That's what we do. We use the crossing the midline of the body with the fingers. We also, I use the tactile because I find that kids that have, and adults that have experienced sexual abuse have a difficult time with the eyes and may need to close them sometimes. And so you can do tapping across the midline of the body. You can do a pulse from one side to another. You can do a sound from one side to another with headphones, or you can do the eye movement. And here's the SUD scale that I'm always constantly checking in. This is just the SUD scale that I use for kids. So the phases of treatment, first sessions, we kind of understand what the struggle is, what the past, like I said, what the past, what the current, what the future. Second phase of treatment, we make sure that the client has several ways of handling emotional stress. This is the complicated way of saying that the client has a safe space. And this may become the targeted treatment for an EMDR, which may mean that as a therapist, you're doing EMDR with the child, but you're doing it to melt in that safe space. You're doing it to uncover what exists within the child, not resolving trauma. So I'm just aware of my time. I'm going to move on to high fidelity wraparound. So what is high fidelity wraparound? High fidelity wraparound is an intensive care coordination model that is driven by values and principles. If you look at all children needing, EPSDT, well child screens and checks, and then you look at children with a behavioral need that may need sort of service coordination, care coordination from the MCO, case management, or CCSS, but then you look at children with complex behavioral needs. And these folks often get, by this system that we talked, those structural determinants that we still have to identify and unlever, can create what is called, I call the runaround for children and families in state custody. And basically the runaround is making a child and family do all kinds of treatment, all kinds of plans. They're all disparate, they're not connected. They have to go to our tables about 20 hours a week in order to make this work. It's just absolutely ridiculous. So the idea here for you, those of you who are not well versed in children's mental health, children are not little adults. Children and youth with serious emotional conditions are a distinct population. So basically, most of them are multi-system involved. Most of them are in juvenile justice or IEP, special education, behavioral health, even child welfare. And so the idea there is to create a team-based structured best practice approach for the planning and coordination of service that lifts up youth and family voice, that utilizes team-based collaboration, that never gives up. And this is the biggest piece. I can give you so many stories on this if we had time. Never give up on kids. They've already experienced that. And if we can be the person that perseveres or persists, absolutely amazing for their well-being. It's outcome-based, it's individualized, it's strength-based, it's culturally competent, and the like. And so this is for kids that are in and out of home placement, like residential treatment, or out of state, or at risk for an out-of-home placement like residential treatment. And they have serious emotional disturbance and functional impairment and multiple domains. So just a real quick thing here, most intensive services, both dollar-wise and community mental health and prevention, focus on this top. If you look at this pyramid, is all kids with serious emotional disturbance. This top percent of the pyramid, most states it's 2 to 5. I propose it's more like 14% in New Mexico, because of what's occurred in our system and because of some of our challenges, but it's the top, very tippy top of the pyramid that need this more intensive care coordination. When I was director at CYFD, we did a pilot with Presbyterian Health Plan and All Face, and here's what we found. And this one, I could just get verklempt right here. Quality of life was greatly improved. 70% of folks who completed wraparound said that. And this is the folks that did not complete wraparound or was the control group, which 4% said quality of life was greatly improved. You can see this other stuff too. So the last piece that I'll leave you with is that the quality assurance and improvement and evaluation plan. This is another piece of the settlement agreement. And why I bring it up today is that we'll include the evidence-based practice, the CANS. It spans the entire Kevin S. settlement agreement. And it's really an iterative way to look at what we're doing, understand what the barriers are, remove those barriers, and then pull the next piece in. So each of the appendices has one element in the QAIEP right now. Appendix A is the CANS. So we're trying to understand, we train the CANS, we've coached on the CANS. CANS are being delivered to our children. We're not counting the juvenile justice children, but we're counting them in our hearts. But the CANS are being delivered. However, why aren't the CANS getting to the courts prior to 10-day hearing or a dispositional hearing? Why aren't the CANS being delivered to our MCOs yet? So we're pulling that in, we're troubleshooting that, we're unhooking some of those barriers. And then once that is resolved, we will exit that. So the idea is iterative, both qualitative using data, qualitative using focus interviews and deeper understanding, and quantitative using data. And that is what I have for you all today. And let me see if you still exist. You do. So any questions or, hi, Kate. And if there's questions in the chat, Leslie, I don't know what they are. So. And you can talk whenever you want.
Thanks. I'm not seeing anything in the chat right now. As you're talking about all these therapies that need the family to be part of, obviously one of the big concerns for people who are attorneys for parents is where the parents fall in that. And I've had a couple of times where the response that I get is, that it has to be the resource parent who's involved because they're doing the day-to-day care. But then it could very well be that part of how this young person ended up in custody is because of the difficult relationship between the parent and the youth. So I'm just kind of wondering, so clinically, what are the issues with that? How do we advocate to get our parents in those therapies? Our parents, when the kids have been removed, how to get those parents in those therapies?
That's a great question. I'm going to give one example. So when I was at CYFD Behavioral Health, we have the infant mental health program, which the primarily target population is for the babies under the age of 4 that come into protective custody, right? And we use CPP, we use child parent psychotherapy. That's an evidence-based modality for that looks directly at the the relationship between the baby and the caregiver. And so the mom's psychopathology enters into that, right? And so we would not want a foster parent to have to, sort of be in that role So what we did was create a foster PIP, and we created basically when there was no identified caregiver and there was no reunification, we could work elements of CPP, but that would be an example that it's really inappropriate for a foster parent psychopathology to enter into that conversation. That's above and beyond. So with MST, I could see that. I could see the foster parent or the resource family or the victim kin, entering into that relationship. They're entering into that service and it being effective. I think what we're going to have to do is as we're rolling these out, maybe even create a learning community with providers serving CISC, because there's going to be certain pieces that come into play where in regular course of treatment with MST, we may be identifying family patterns that have, sort of a root back in that foster parent's childhood. How's that going to feel? So this is a thin line that we're going to have to, as we get into clinical practice, we're going to have to tease this out. But MST is an example where we could absolutely use somebody, a caregiver, and not the reunification family. FFT is another example of that. DBT, absolutely. A resource family or foster family could enter into that. Again, with that conversation with the clinician, that I'm not, these are my boundaries. This is what I'm not going to talk about. This is how I can be available for this child. And this is what I can do, but we're not going to talk about my other children, or we're not, well, however that looks. So it's a little bit funky, but that's the truth of it. But if we start to identify reunification elements early, and a mom was able to pretend get stabilized in housing or on her with her substance use, and said, yes, I'm moving towards reunification, and now I want to enter into a functional family therapy with my child. Absolutely. Absolutely. Any of these services for families that are looking to reunify and parents that are fairly stable.
Thank you.
Thank you.
And just as a reminder, we are 3 minutes before 1. If any of you need to go, please remember to do your post-session survey, but our session does not end until 1:15 p.m. If anyone has any more questions or anything. Any more questions for Bryce? Kristen?
Thanks. Realistically, how many of these services are available? Is this available all through the state? Can somebody in Catron County get to this? Can somebody in Union County get to this?
Hi, Kristen. No, but that is the requirement of the settlement agreement. And so that's what we're aiming to do, is make this broadly available statewide. Take this with a grain of salt, but last time I checked, there were about 3 organizations in Albuquerque serving adolescents in DBT and dialectical behavioral therapy, and 2 in Santa Fe, and that was it throughout the state. Functional family therapy, there are a couple of sites thanks to CYFD, Behavioral Health Services, that's been seeding that with a grant with Functional Family LLC partners. So that's in development, and I can get you a list of where those are. They should be on the, we geo-mapped all the services on pulltogether.org. So I'll look for that and I'll send that to you. MST, no. This is one of the things that went crashing down in 2013. We had a lot of children's behavioral health providers that were really impacted, that really served this population well and broadly. And so MST, I think we've got 8 sites around the state. I can get those to you. EMDR is broadly available. There's just not a differential payment through Medicaid. So I don't know how many of those practitioners are actually Medicaid practitioners, but we're going to find out. So that's going to be an enhanced rate. And then TFCBT, there are some folks that could be doing it, but we don't know.
I know that I practice in the 13th Judicial District, so Sandoval, Valencia, and Cibola, and only Sandoval regularly participates in any of these. I just don't think it exists in Valencia or Cibola yet. And so, and there's like one provider. So I guess that's the one you need to work on to help them provide all this.
When you say Sandoval participates, you mean Sandoval County Behavioral Health?
Sandoval County CYFD routinely tries
CYFD.
the parents into the appropriate therapy. And I have seen all of these modalities used in cases in Sandoval. But like I said, not Valencia and not Cibola, and definitely a need in both of those counties for this.
Yeah. Well, another element that I didn't talk about, Cherie, is that, you know, the teaming, the child welfare approach to teaming, which is we're working with the child welfare policy and practice group out of Alabama, Frida Baker, if you know her, she's awesome, and Cornelia Spurd. And so they've helped a lot of states reform by teaming, by multidisciplinary teams. So that's part of what what this settlement agreement has as a design, is that certain meetings are required participation for folks, right? And I can get you that list, but again, that's available on the cyfd.org website. I think that we labeled it IPP, which is individualized planning meetings. That's the language of the settlement agreement. IPP meetings and non-IPP meetings, so you can see for yourself what that is. But basically calling for a meeting in any condition like that when you're looking at an out-of-home placement or trying to uncover a child's needs, I would say that is your advocacy spot and mine. We should be asking for meetings.
Well, I have one conflict case in Albuquerque, and the permanency planning workers, oh yes, let's have an IPP meeting. Here are dates of availability. And she hadn't done any of the groundwork to make it work. So now my client is very angry that she's not going to get an IPP meeting because there's not enough time before the TPR, basically.
Yeah, well, you can go up the chain if you want, and you know, I can put my email in the chat. I don't work for CYFD anymore, but I work very closely with them, and I know that's the aim of Emily Martin. HSD.in.gov. So, and in some ways, none of us are prepared. We're all just having to start to do it. And so the training and coaching that we've developed through the Child Welfare Policy and Practice Group should help most folks. Maybe not everyone, you know, feel comfortable with leading a team meeting, but even if we're ill prepared, we should still do it. Kristen?
I don't know if this is as much a question for Bryce, but as a comment to the attorneys. I mean, to me, this is an argument that the state is not making reasonable efforts if they have not, if they are not able to show how they are actively working to get these services into these underserved communities. And I realize you're likely to not get very far with that in front of a judge. But if you keep, if enough of us, well, like I'm still in the direct practice back in the day, if enough folks keep making that argument, bringing it up in appeals, and it becomes an overwhelming wave of, look, we don't have the services we need. You know, I think that could make a difference in this. But we also know we're a tiny population, and just having enough people, you know, it takes 6 months to get into a dermatologist in the center of the state, let alone other parts, let alone somebody who knows DBT. Thanks.
Yeah, and just so if I could respond to that, EPSDT is equally important, and you know, our children seen by physicians and not being identified for any developmental challenges, not across the board, but in all cases. And I know that ECHO was interested in possibly, I was trying to get Dr. Aurora to consider an EPSDT or an EBSTAT ECHO, because that's another place you take your children to the doctor, and we do pretty well at CYFT with well-child checks within that first 30 days, which is an EPSDT requirement. Well, let's load it. Let's load it with understanding so doctors can start to identify some of these. And once and through EPSDT, if I'm a doctor and I do identify some of this stuff, then it's mandatory that it follows up, and it's mandatory that the child gets those needs to, you know, ameliorate any harm in the least restrictive setting and not fail up. And it's mandatory that that is provided for that child, even if it's not in the state plan. So I think there's another lever there that we could potentially use. But just to tell you really quick what we're doing for the state in terms of getting these practices out there, is we have done geomapping. We do understand that it is broadly needed. And so we're looking at the composition of each of these evidence-based practices and anchoring them. And so the NMSU is ready to receive those applications from providers. We're assuming all those costs up front, the training and fidelity, and then these rates will be established so providers can carry on and sustain that evidence-based practice, again, whatever, regardless of what happens in the administration. So we are getting there. We're just not there yet. Leslie?
So I had another question when you were talking about requiring a diagnosis for some of these evidence-based practices, that one of the frustrations that we often have with the psychological evaluations that we get as part of these our cases, which they tend to be not the best. And a lot of times it's a rule out. So can someone be referred, for example, like for EMDT or for DBT, if it's a rule out and not a confirmed diagnosis?
Absolutely. I mean, so for EMDR, you know, it could be something, I'm speaking off the cuff here in terms of how I would practice. There needs to be identifiable symptomology for trauma. Does there need to be a PTSD diagnosis? No. EMDR National says no, as long as there's identifiable symptomology. So there's this other diagnosis that we utilize in our field, which is called adjustment disorder, which is just that you and me have something really horrible happen. We have a 6-month period where we're freaking out, we're adjusting, but we don't have all the markers of trauma. You have to rule that out. That can't be a persistent diagnosis that stays with a child or an adult. You have to then say they've recovered, or they have PTSD, or they have something else. But so the low barrier threshold, I think, is what you're looking for. And in reality, you know, Medicaid is not necessarily organized that way in terms of prevention, and does need a serious emotional diagnosis in order to get some of these higher end bundled services like DBT. So it could be major depression, it could be bipolar, it could be PTSD, but an SED diagnosis. MST is usually oppositional defiant or conduct. If it's just trauma, don't send them to MST, folks. Functional family therapy, if it's just trauma, do it, because that's a whole different ball of wax there. So it's a little mixed bag, but Kate Gibbons is going to tell us good things. Go, Kate.
I don't know if I can tell you good things, but I do have a question for you about building capacity across the state for the evidence-based treatments. What are your top 3 to 5 things that you think that the state MCOs and providers and this group can do to expedite building capacity or accessibility, building out that availability so that people and families get matched to the treatment they need, not, oh, we don't have functional family therapy, so you're getting MST.
Right. I think it looks
I'm sorry,
different.
we want to pick your brain before March 3rd.
I think it looks different depending on where you are, right? I mean, this is my soapbox, so take it with a massive grain of salt. Just throw it out if it doesn't make sense to you or if you don't believe it. I think that a lot of our behavioral health models in New Mexico are built on big box urban models. And we don't do a lot of deeper digging and understanding what it takes in a HRSA designated rural or frontier area to build behavioral health business. It does not look like bricks and mortar. It does not look like, that everything is one-stop shopping. And you got one organization, that does everything, or multiple organizations that do everything. It's going to look really different. And I've had this conversation with some folks, and the opportunity next year is for Pew Charitable Trusts. I've contracted with them to help us on just that, on rural behavioral health financing models. So right now, the ideas would be school-based health centers can provide some of this, right? Some places, FQHC, our federally qualified health center, especially in our tribal areas, our FQHC without the four walls. There's some fabulous examples of what they do there. And so if we could approach a FQHC without the four walls for our frontier areas, not just our tribal areas, I think we'd really be getting somewhere. But right now, what we're going to do is take those current existing 387 behavioral health providers who serve children in state custody, tap them to see if they want to be evidence-based providers. Already done that via survey, and I told you they said yeah, as long as you do the rate development. We've done with that. And then, just getting it out broadly, but until we create pipelines from our institutions of higher education to our communities, we are just going to be continuing recycling this particular issue, which is a workforce issue nationally. And New Mexico, unfortunately, is one of the biggest exporters of people like me because we can get paid so much better in other states. And so that's why raising the rates, keeping them raised, evidence-based practice, again, raising the rates, raising the bar for outcomes, literally. These are some of the levers I think that make some sense, but the pipelines are absolutely key.
Bryce, the list that you, oh, go ahead.
Me? I'm good.
The list that you mentioned, what do we have? You said you could send me a list. Is that something like do we identify that in San Juan, Rio Arriba, Taos, that we have these particular kind of therapies available?
So here's the rub on that. So MST's already been on the fee schedule. So we track that by claims. So yes, we can tell you exactly where MST is, both because of their national credentialing body that's out of University of Denver that meets with us regularly, that tracks that, as well as claims. We have no specific claims CPT or HCPCS code for DBT, for functional family therapy, for EMDR, and for TFCBT. So we're not able to show its prevalence. And in those surveys that we did find a lot of folks who said they were doing some of that. And we thought, oh, okay, awesome. Some low hanging fruit. Maybe they'll be interested in getting trained and certified and getting this higher billable rate. But that's the rub right there. I would definitely say that, MCOs have some skin in the game in this, as they, we pass on the contractual obligation to them to fill. HSD does, right? And so part of the contractual obligation about maintaining the service array is about network adequacy. I wouldn't say I completely agree with how we formulate network adequacy now, but I would say that once we add and stack some of these have-tos in there, that's going to look a little different. And if we have a CIS CMCO, we're going to be able to task them with building, identifying, tracking, referring, closing the loops on some of these for our communities and our providers. But that's kind of the rub, Kristen, is that we're not able to see exactly where all of this is happening other than survey.
Would it be worth the time of an attorney or a social worker to just go to our own health insurance and see what providers are in a particular area code, that kind of thing. I'm just trying to figure out how attorneys and social workers can build the argument that here's a service we need. And we know that Jerry Johnson does EMDR in Catron County, but he's not contracting with the department. I mean, is that?
Actually, that's brilliant, because that situation would be that you've identified a therapist that they were willing to take money from CYFD to provide that service. That could remove that barrier, and then pretend we welcome them into the Medicaid world and they become contracted as a Medicaid provider because they know they can get these higher rates. They know they can, I mean, that's the idea. We've increased the behavioral health and psychiatric Medicaid presence, not presence of clinicians and practitioners, but we've moved a lot of them over to Medicaid. And so that's been, you know, that scenario is a great one. If there's a private practitioner that is developing, I mean, that is delivering the service, I'd want to vet them. Because honestly, like DBT, it's about 4 weeks of training and then all kinds of things. And PESI, which is one of those CEU places, offers a 6-hour DBT. If somebody's credentialed in PESI for 6 hours, I got nothing. There's nothing there. That's not fidelity. That's not interesting. Don't do it. So that's why we've selected these national oversight bodies or fidelity bodies that have that grit, that have that layering, that own that practice. And Marshall Linehan's behavioral tech is the example I'm giving you about DBT, is the one that we have selected. So it's a much higher standard when it comes to fidelity. And so in that scenario, that provider was a PESI trained. I wouldn't be interested, no offense, but I may be interested in getting them DBT trained, because that would be fabulous. Well, happy Valentine's Day, everyone. Thanks for coming.
Yes, thank you so much for your presentation, Bryce. And
You're welcome,
again, just as a reminder, please complete your post-session survey. And our next echo will be March the 4th, 2023. The topic is the importance of your emotional IQ. All righty.
Thank you.
I did what Bryce said. Happy Valentine's Day, everyone. Have a good one.
Thank you so much, Bryce.